So, I want you to just imagine a scenario for a second. Imagine you're diagnosing a severe chronic medical condition, like one that fundamentally alters your quality of life.
Right.
And the only way to actually see how much damage has been done is by taking an invasive, really painful tissue biopsy. You literally have to, cut out a piece of the problem to understand it.
Which is, yeah, it's awful.
Right. But then, almost overnight, this new technology emerges, and it allows doctors to see the exact same microscopic details, the literal cellular structure of your tissue, using nothing but sound waves and light.
hmm
No scalpel, no stitches, just immediate objective truth.
Yeah, and we are really moving from this paradigm of guessing or relying on subjective feeling to a paradigm of just absolute measurable precision.
Yeah.
The field of regenerative medicine is experiencing a massive leap forward. Because of this, specifically, when we look at women's health, the stack of clinical trial data, histological research papers, and peer-reviewed studies we are looking at today all center on one incredibly specific breakthrough. It's how we use high-frequency pelvic ultrasounds and optical imaging to actually monitor the regeneration of intimate tissues in real time.
Right. And we are looking at this diagnostic revolution through the lens of a highly innovative treatment called polynucleotide therapy.
Exactly.
We're talking about addressing genitourinary syndrome of menopause or GSM and vulvovaginal atrophy, which is known as VVA.
Okay.
Okay, let's unpack this. Because to truly appreciate the optical physics and the acoustic technology tracking this healing, we have to understand the biological reality of what is actually breaking down in the first place.
Right, because to grasp the magnitude of the problem, you have to look at what happens to the vaginal epithelium during menopause.
Okay, so what does happen?
Well, this tissue is heavily dependent on estrogen to maintain its structure and function. It's composed of something called stratified squamous epithelium.
Which means what exactly?
Stratified just means it has multiple distinct cellular layers, almost like a brick wall.
Oh, okay. Like a protective barrier.
Exactly. And when estrogen levels drop, that vital stimulus vanishes, and those protective layers basically begin to collapse.
So the tissue it loses its structural integrity completely.
It does, yeah. We see a massive drop in collagen and elastin production. The local blood vessels start to disappear too, which means, oxygen and nutrients aren't making it to the surface.
Wow.
And that leads to severe dryness, dyspareunia, which is painful intercourse, and microfissures.
Microfissures, like tiny tears.
Yeah, essentially tiny agonizing tears right in the mucosal lining.
That sounds horrible. So what's the typical fix for that?
Well, the traditional medical approach has mostly been about symptom management, right? Usually with localized hormones or simple lubricant.
Just putting a Band-Aid on it, basically.
Right. But the data points us toward a completely different biological intervention today. Polynucleotides, or PNs.
Right, the polynucleotides.
In the medical-grade formulations used in these studies, these are highly purified long chains of DNA and RNA building blocks. They're typically derived from salmon DNA that undergoes rigorous thermal sterilization, just to remove any proteins that might trigger an immune reaction.
So we are dealing with pure biological building blocks.
That's correct.
But introducing a long chain of DNA into the environment of a collapsing cell wall, that doesn't automatically mean the cell knows what to do with it, right?
Yeah.
How are these polymers actually reversing the atrophy at a cellular level?
They operate through a few distinct, really fascinating mechanisms. So first, they target specific receptors on the surface of fibroblasts,
And fibroblasts are
the primary cells responsible for manufacturing connective tissue.
got it.
The most critical one is the CD44 receptor. When a polynucleotide polymer binds to a CD44 receptor, it causes a conformational change. The receptor literally changes its shape, which sends a signaling cascade deep into the nucleus of that fibroblast.
Oh, wow. So it's communicating with it.
Exactly. It essentially flips a switch, telling the dormant fibroblast to wake up, proliferate, and start aggressively synthesizing new type I and type 3 collagen.
That is wild. It's commanding the local cellular machinery to rebuild the structural scaffolding.
Yes.
But wait, the tissue is also highly inflamed at this stage, right? Just building collagen wouldn't solve the chronic inflammation that comes with GSM.
No, it wouldn't. And that brings us to the second mechanism. Polynucleotides also interact with adenosine A2A receptors.
Okay.
When these specific receptors are activated, they powerfully downregulate the production of pro-inflammatory cytokines.
Cytokines are the immune system alarms, right?
Basically, yeah. The chemical alarm bells of the immune system, keeping the tissue in a constant state of red alert. The PNs silence those alarms. On top of that, they act as free radical scavengers.
Meaning they clean up the damage.
Right. The oxidative stress in atrophic tissue generates free hydroxyl radicals, which are these unstable molecules that just tear apart healthy cell membranes. The polynucleotide chains physically bind to and neutralize these radicals.
Okay, that makes sense. Let's talk about the barrier function, too, because the studies specifically mention Claudin-1. If the tissue is tearing and forming those microfissures you mentioned, it means the cells aren't holding onto each other properly.
Right. Claudin-1 is a key protein in what we call tight junctions.
Tight junctions.
Yeah, if the cells of the epithelium are bricks, tight junction proteins are the mortar holding them tightly together so nothing can leak through. Polynucleotides actively support the synthesis of Claudin-1, which restores that mechanical barrier.
Okay, so I picture the atrophic tissue like a dried out brittle sponge that's sort of crumbling at the edges.
That's a good way to look at it.
And when you introduce these polynucleotides, they form a hydrophilic 3D gel matrix. It's like injecting a highly specialized hydration gel into the sponge that provides immediate mechanical moisture, right?
Yes.
But simultaneously, it's acting as a foreman, directing the sponge to rebuild its own internal structural fibers and seal up its own cracks.
Precisely. The physical presence of the gel matrix offers this immediate relief, while the biological signaling kicks off a long-term reconstruction project.
Here is where the methodology gets critical, though. If a patient undergoes this therapy, and we claim that fibroblasts are multiplying and collagen is forming and tight junctions are repairing, no ellipses. I mean, how do we prove it without cutting out a piece of the vaginal wall?
Yeah, that's the big question.
Because historically, doctors relied on subjective measurements, right? Asking a patient to rate their pain on a scale of 1 to 10, or using vaginal pH tests, which I read those can be thrown off by something as simple as the type of soap a patient uses.
Oh, absolutely. The historical lack of objective measurement is exactly what these new diagnostic tools are solving. The primary imaging modality the sources focus on is high-frequency pelvic ultrasound, specifically looking at submucosal thickness.
Right, the transvaginal biplanar probe with linear crystals, and the phrasing linear crystals seems to be a major point in the clinical literature here. Why wouldn't a standard curved ultrasound probe work just as well, like the ones they use for pregnancy?
It really comes down to the physics of acoustic waves. A traditional curved probe emits sound waves that fan out in a divergent pattern.
Okay.
That's great for getting a wide view of an entire organ like the uterus, but when you are trying to measure something entirely flat and superficial, like a mucosal wall, a divergent beam creates geometric distortion at the edges.
Ah, so it skews the image.
Exactly. A linear crystal array, on the other hand, emits sound waves completely parallel to one another, striking the vaginal wall perpendicularly. This eliminates the distortion and allows for absolute millimeter-level accuracy.
Wow, and the measurements we were talking about are incredibly slight, aren't they?
Very slight.
The baseline data for a healthy premenopausal vaginal wall thickness, which is often abbreviated in the literature as VWT, it averages around 4.17 millimeters.
Right.
But in a patient suffering from severe GSM, that thickness drops to about 2.25 millimeters.
Yeah, the mucosal lining loses nearly half of its mass. So with linear ultrasound, clinicians can establish that 2.25 millimeter baseline, administer the polynucleotide therapy, and then track the submucosal thickness actually increasing over the following weeks.
It takes the guesswork entirely out of the equation.
Completely out of it.
But I want to challenge this idea that thicker automatically means better.
Okay, how so?
Well, if I have a thick wall of dense fibrotic scar tissue that's not healthy, functional mucosa, how does ultrasound differentiate between healthy, flexible tissue and rigid, non-functional tissue?
That is the crucial limitation of standard ultrasound. And it brings us to a highly advanced application called shear wave elastography, or SWE.
SWE.
SWE doesn't just measure static distance or thickness. It measures the actual mechanical stiffness of the tissue.
Wait, how does an acoustic wave measure stiffness?
So instead of just sending a standard pulse to bounce back, SWE sends a specialized, focused acoustic pulse deep into the tissue.
Okay.
This pulse is so strong that it actually pushes the tissue slightly, generating a shear wave that ripples laterally sideways away from the pulse. It's almost like dropping a stone into a pond and watching the ripples move outward.
Oh, I see. So the ultrasound is tracking those lateral ripples.
Yes. The software tracks how fast that shear wave moves through the tissue. In a dense, rigid, fibrotic material, the wave travels very quickly. In soft, elastic, compliant tissue, the wave travels much slower.
That is brilliant.
Yeah, by measuring that velocity, the system calculates Young's modulus, which is a fundamental physics equation used to determine the elasticity of a solid material.
So it's essentially sonar being used to test shock absorption. You can have a thick piece of rubber and a thick piece of glass. They might look the same on a standard measurement, but the shear wave proves the rubber has bounce and the glass is rigid.
Exactly.
So SWU proves that the polynucleotides are actually restoring the compliance and elasticity to structures like the perineal body, not just bulking them up with scar tissue.
Yes. What's fascinating here is the statistical reliability of these ultrasound methods. In clinical trials, they use something called an interclass correlation coefficient, or ICC, to determine if a test is actually useful in the real world.
And what's a good score?
Well, a score of 1 means perfect reliability. These ultrasound and SWE protocols consistently score over 0.9.
Wow. Which means the measurements are practically operator independent.
Right.
If one clinician performs the scan on Monday and a completely different clinician performs it on Friday, they get the exact same numbers. The human subjectivity is removed.
Yeah, it creates a standardized objective baseline for tissue regeneration that simply did not exist for these conditions, even a decade ago.
Okay, so ultrasound and elastography give us this incredible view of the macro structure, the wall thickness and the elasticity deep in the submucosa. But if we think about the patient's actual experience, the burning, the micro tears, the dryness, all of that is happening at the literal microscopic surface. An ultrasound isn't going to show us the tiny individual capillary loops that are failing to deliver blood to that surface.
No, it won't.
So how do we visualize that microvasculature without taking a scalpel and doing a biopsy?
Well, when we need to see the cellular surface, we have to switch our diagnostic medium. We move from sound waves to light waves. This is the realm of the optical biopsy, primarily using optical coherence tomography, or OCT.
Let's delve into OCT. It functions somewhat similarly to ultrasound, but it relies on near-infrared light instead of acoustic pulses, right?
Yeah, and because light waves have a vastly shorter wavelength than sound waves, the resolution OCT provides is just staggering. We're looking at a resolution of 5 to 15 micrometers.
That's tiny.
It is, and it can penetrate up to 1.5 millimeters deep into the mucosal tissue.
So the clinician is looking at a screen and literally seeing the individual cellular layers of the epithelium and the lamina propria beneath it.
They are.
They can watch the tissue stratify and reorganize itself in real time. But the other tool the source is heavily detailed, and this one is truly remarkable, is incident dark field imaging, specifically utilizing a device called the cytocam.
The cytocam is essentially a handheld, highly specialized video microscope. And the key to its function is the specific wavelength of light it emits.
Right.
It doesn't use white light, it uses a highly concentrated green light.
And the physics of why green light is used here is brilliant. It's all about light absorption and the color spectrum.
Exactly. The protein in our red blood cells, hemoglobin, maximally absorbs green light. So when a clinician places the cytocam against the mucosal surface and illuminates it with green light, the surrounding tissue reflects the light back and appears bright.
Okay.
But the red blood cells absorbing the light appear stark black.
It's like shining a green flashlight against your palm in a completely dark room.
Cool.
The light is trapped by the blood, perfectly illuminating the entire hidden highway system of blood vessels just beneath the skin.
That's a perfect analogy. In severe VVA or GSM, that microvascular network is severely degraded. There are very few blood vessels, meaning the tissue is starved of oxygen and nutrients.
Right.
However, one of the most critical effects of polynucleotide therapy is the stimulation of VEGF, which stands for vascular endothelial growth factor.
VEGF is the biological signal that tells the body to initiate angiogenesis, right? To grow completely new, healthy blood vessels.
Yes, and with the cytocam, clinicians can literally watch those new vascular highways form over the course of the treatment.
That's amazing.
It is, but it also gives them a crucial measurement called focal depth, or FD.
Let's explain focal depth because it ties directly back to how dangerously thin the epithelium has become.
Right. Focal depth is the precise distance from the tip of the cytocam lens on the surface of the tissue down to the very first visualization of flowing red blood cells. The microcirculation lives in the lamina propria, which is just beneath the protective epithelial layer. If the focal depth is extremely shallow, it means the blood vessels are practically exposed on the surface because the protective epithelium has eroded away.
Which explains the severe burning and pain patients experience.
Exactly. As the polynucleotides signal the fibroblasts to rebuild and the epithelium thickens and stratifies, the focal depth increases. The optical biopsy proves that the protective barrier is being restored over the vulnerable blood vessels.
You know, seeing this from the patient's perspective adds a whole new dimension. Women dealing with these atrophic conditions have often spent years navigating a medical system that dismisses their pain,
Oh, absolutely.
telling them it's just a normal part of aging. When a patient can look at an OCT monitor or a cytocam feed and see the absolute, irrefutable data watching their vaginal wall measurably thicken and new blood vessels form, it must completely change their psychological relationship with their diagnosis. It validates their reality with hard data.
It restores a sense of agency. The treatment is no longer a mystery happening inside some black box. The clinician and the patient are actively watching the regeneration together.
So we have the biological treatment, the polynucleotides acting as the cellular architects, commanding the tissue to rebuild. And we have the diagnostic tools, the high-frequency ultrasound, SWE, OCT, and cytocam, acting as the building inspectors, verifying the integrity of the work down to the micrometer.
Right.
When we put these together in the real world, what does the clinical timeline actually look like?
Well, the clinical outcomes documented in the trials are profound. By pairing this specific regenerative therapy with precise monitoring, the data shows that vaginal hydration increases by nearly 60% within a matter of weeks.
Wow.
And the debilitating symptoms, like burning and dyspareunia, drop by over 70%.
A 70% reduction in pain is life-altering, but these are biological molecules. They don't sit in the tissue permanently, right? The gel matrix eventually breaks down.
It does. The body has native tissue enzymes called DNases, which act like molecular scissors. Over time, these DNases slowly chop up the long polynucleotide chains. But this is where the biology gets incredibly elegant. The breakdown of the product is actually a vital part of the therapeutic process.
Wait, really? How?
It's thanks to something called the enzymatic salvage pathway.
Enzymatic salvage pathway. Okay, let's really detail how this works because it flips the idea of a treatment wearing off completely on its head.
Yeah, it does. When the DNases cut the long polymer chain, they leave behind individual free-floating nucleotides in the extracellular matrix.
Right.
The local cells, which are constantly sustaining damage from daily life and cellular metabolism, scavenge these free nucleotides. They pull these individual building blocks inside the cell membrane and actively use them to repair their own damaged DNA.
It is a literal biological recycling program. The long-chain polymer acts as the initial signaling mechanism and the physical hydration gel. Then, as it breaks down, it serves as a slow-release reservoir of spare parts, fueling ongoing cellular repair long after the gel itself is dissolved.
If we connect this to the bigger picture, this salvage pathway is why the therapeutic benefits outlast the physical presence of the polynucleotides.
That makes total sense.
But eventually, that reservoir of recycled nucleotides will run dry. And this is where the diagnostic technology proves its ultimate value.
Because doctors don't have to wait for the patient to call and say the burning has returned.
Exactly. Using the high-frequency linear ultrasound and the cytocam, a clinician can monitor the exact timeline of the tissue's structural integrity.
They can see it coming before the patient feels it.
Right. They can look at the submucosal thickness and the focal depth and see the precise moment when the collagen synthesis begins to plateau or even dip. And then they can administer a maintenance dose of polynucleotides before the structural collapse ever reaches the surface, entirely preventing the recurrence of the physical symptoms.
Here's where it gets really interesting. We aren't just discussing a way to alleviate a symptom like dryness. The combination of this biological signaling and real-time optical tracking means we are fundamentally reversing the biological clock of that specific tissue, and we have the indisputable hard data to prove it. We aren't treating the ghost of the disease, we are systematically rebuilding the house it lives in.
It represents a total paradigm shift. We have moved from a reactive model of symptom suppression to a proactive model of quantifiable cellular regeneration. The acoustics and the optics allow us to guide the biology with total precision.
So, to synthesize all of this for you listening, Conditions like genitourinary syndrome of menopause can absolutely devastate intimate tissues,
Mm.
stripping away the collagen, the elasticity, and the vital microvasculature.
Yeah.
But polynucleotide therapy offers a sophisticated mechanism to signal the body to rebuild itself from the inside out, utilizing CD44 receptors, downregulating inflammation, and eventually feeding the body's own enzymatic salvage pathway. And crucially, thanks to high-frequency ultrasound with linear crystals, shear-wave elastography, and optical biopsies like OCT and cytocam, we have eliminated the need to guess if the treatment is working.
Right. We don't need a scalpel to prove the tissue is healing.
No, we don't. We can literally watch the regeneration happen in real time, cell by cell, micrometer by micrometer.
It is a remarkable convergence of molecular biology and physics. But, analyzing this stack of research also leaves us with a provocative thought to mull over.
Oh, what's that?
Well, if we have successfully cracked the code on using polynucleotides to signal the regeneration of intimate mucosal tissue, and we have the acoustic and optical technology to track this healing at the cellular level without a single incision.
Could this exact combination be the future blueprint for repairing damage in all of the body's mucosal linings?
Exactly.
Wow, that opens up massive possibilities. Where else could this apply?
Think about the devastating mucosal damage in the digestive tract caused by Crohn's disease or ulcerative colitis.
Oh, wow.
Yeah. Think about the chronic degradation of vocal cords in singers or public speakers, or even severe inflammatory conditions lining the respiratory tract.
Right.
If we understand how to command the local cellular machinery to rebuild, and we can use light and sound to map that repair non-invasively, the frontier of regenerative medicine might just be getting started.
That is an incredible thought to leave on. From sound waves and green light replacing the scalpel to the potential of healing the entire body's mucosal network from the inside out. Thank you for joining us on this deep dive. Keep exploring, keep questioning the data, and as always, stay curious.